Okay, well, hello everybody. Welcome to today's webinar. This is our first LACNETS webinar of the year. Thank you so much for tuning in. I'm Lindsay, I'm the Director of Communications for LACNETS. I've been with LACNETS for 5 years now, and I'd like to introduce my colleague.
Hi, I'm Lisa. I'm the Program Director of LACNETS, and I've been with LACNETS since the beginning of 2018.
And our next webinar will be on April 14th at 12 p.m. Pacific time. This will focus on PRRT with NET experts, including Josh Mailman, Lindy Gardner, and Dr. Thomas Hope. So save the date on that. And then we have a new virtual NET support meeting that we've been doing. We started it last week. It's going to take place every Wednesday at noon Pacific time. You can go to our website to register for both of those events. And then lastly, one more save the date that I want to announce is May 6th, a Wednesday. We also have a webinar at noon Pacific time. It's going to be about palliative care with palliative care nurse Redwing Kesar. She's the author of What Matters Most, and she'll be talking about meaningful advanced care planning as a gift to your loved ones. And then last reminder from me, stay up to date on the LACNETS social media channels, Facebook, Instagram, and Twitter. Our handle is @LACNETS. You can find us on all three of those platforms. And from here on out, I'll let Lisa take it away.
Thank you, Lindsay. We just want to acknowledge it's quite an unprecedented time. And as such, there's probably a lot of changes going on in your life. We have a lot of resources available for you, and those resources can be found on our website, lacnets.org, LACNETS, LACNETS.org. We have a resources page with a list of different resources, including links to the pharmaceuticals that might be able to arrange home injections or financial aid. Also, our recent blog article, Finding Calm During Coronavirus, includes links for things you can do while you're sheltering at home, and things you can do while you might be going out to protect yourself, and also links to the page that Josh Mailman set up with FAQs regarding NET and COVID. While you're at home, you might want to take advantage of the quizzes that we have. We have 5 up now, and the recent ones also correspond with NetRF's podcasts. So that would be a nice way to test your comprehension after listening to the podcast. As always, we have the Net Vitals patient and physician communication tool, so you can brush up on that. And that can all be found on our website. We have several programs to help support you during this time, including our Net Connect program, where you can partner with a peer mentor, or our health coaching program. The slide just came up. That's available for Southern California patients or caregivers who are looking for someone to help them make positive behavioral changes so that they can thrive in their NET journey. So we have lots of things going on. And again, we have the weekly virtual support group, so you can just connect with other people and network. Even though we're at home, we can still connect over Zoom and see each other and hear each other. So with that, I want to introduce to you our excellent doctors here at City of Hope. Dr. Dan Lee is, as you know, is the GI oncologist and NET expert at City of Hope. He's the co-director of the Neuroendocrine tumor program at City of Hope, along with Dr. Singh, and he leads the City of Hope NET Tumor Board. He's very active in NET research at City of Hope, and he is also very involved in NET education, collaboration, and advocacy. Dr. Lee serves on several national committees and task forces, including the Scientific Review and Research Committee of NANETS, and the Continuing Education Committee of NANETS as well. He's been involved in Healing NETs, and he was recently honored with ASCO's Top 40 Under 40 Award. He is a true NET champion, and you've heard me say that Dr. Lee has encouraged us to dream big and reach for the stars. So we're honored to have his collaboration and support. and you'll be able to ask him some questions as well in the Q&A later. I also want to introduce our speaker for today, our presenter, Dr. Sue Chang, who's the clinical professor, assistant clinical professor in the Department of Pathology at City of Hope and an integral part of the NET tumor program. So she leads the review of pathology for NET patients that come through City of Hope and leads the tumor board from the pathology side. She's very actively involved in NET-specific research at City of Hope, and we were honored to hear her speak at the 2018 NET Cancer Day Symposium. Everyone enjoyed it very much, and that's why we wanted to invite her back to share with us again. We learned so much from her, and we hope and know that you'll learn a lot from her today too. So Dr. Chang, thank you so much, and we're honored to have you.
Thanks, guys. Thank you to LACNETS and to Dr. Lee for inviting me here today. And thank you all for taking time to listen in and join us today online. I wanted to start with my talk, and hopefully we'll have some time for questions. There are a few links in here, but I tried to keep the URL short so that even though there's no hyperlink, you guys can hopefully remember the websites that I'm going to be showing up here. Today we'll be talking about neuroendocrine neoplasms under the microscope. I wanted to introduce who your pathologists are and also what your pathology report is all about. I have no financial disclosures or conflicts of interest to report. So this is our itinerary. First, we're going to talk about what happens to tissue when it's taken from you as a biopsy or during surgery and then handed over to the pathology department. I'm one person, but I actually stand for hundreds of people who work in the laboratory department who are working every day to make sure that you can get the answers and the correct diagnoses that you need. Then we'll be talking about what happens when I sit down to craft a pathology report, the ways that I might get tissue or slides coming to me, the different sources, the different styles of report that I might be writing. We're going to talk a little bit, because this is a pretty specialized zebra group, neuroendocrine neoplasms. I'm going to show you some pictures, what it looks like under the microscope, try to work through the monologue. So my internal monologue, I'm going to make it external and show you guys the way it is I think about these when I start looking at a neuroendocrine neoplasm under the microscope. There are some components of the pathology report I think would be really interesting to make sure our patients and our caregivers are have a chance to note the next time you see it. They tend to be common throughout all pathology reports. So I'm going to show you examples from City of Hope pathology reports, but honestly, any pathology report from any institution, any hospital, any laboratory should show very similar components, if not in the same place, at least somewhere in the report. And then I'm going to talk a little bit about some of the sea change that's going on in neuroendocrine neoplasm thinking and algorithms, partly on our end, the World Health Organization and pathology societies, to give you a little sense of the terminology that might be different from the first time you were diagnosed or the first time you ever heard about this disease. There's a few terminology changes that have come up. I do have a couple of pictures. Most of them are pretty cleaned up, but if you have a hard time with blood or organs or things, maybe look away for a little bit. I'm usually, when I give this talk, in front of actual people, and so I can see pale faces if it looks a little bit too much, but I trust that you guys will look away if it's a bit much. So this is the first step. When you have a surgery or a biopsy, the tissue comes in a container, a sterile container, and it comes to our laboratory for what we call gross examination and dissection. So a pathologist or a pathologist assistant will take a look at the tissue and try to determine what looks like normal tissue and what looks like abnormal or tumor tissue. This is for a resection. For example, if you have a portion of liver taken out, we'll look and see how big is the tumor, how much of the tumor occupies the entire liver specimen, if there's any change by treatment that we can see with our eyes, and then we make a sample from this area. So we cut into it with a scalpel using forceps to dissect out what we think is of interest. These pieces of tissue have to be small enough to fit into this thing on the right, which we call a cassette. So this is a cassette, and it's about the size of those small Post-its that you might see. So it looks like a little plastic tray. It's got little grates in it, and we put the tissue inside. We put the tissue inside because we're going to put this entire cassette, once it's put a lid on top, we put it into formaldehyde, and that fixes the tissue so that the cellular processes stop going, and then all of the chemical bonds and the proteins are fixed in place so that it's preserved. Here are a few of the many machines that we have that we use for tissue processing. It's like a very large bath, and then the bottom part has all these different chemicals that cycle in and out through this little bath over hours and hours. The shortest one that we have, which is not necessarily used for NET specimens, but for other ones, is 4 hours. The general rule, though, is about 8 hours to 12 hours to 16 hours, depending on the thickness and the type of tissue. And when we close the system, there is no stopping it, not really. You can pause it, but it's a closed system and it's locked down. So once we put the tissue in, we have to walk away for minimum of 8 hours. It's hands-off time. There is no Instapot version of it that speeds anything up. People have looked all kinds of ways to see if we can make things go faster. And it really turns out that for the things that we want to do further on down the line, which I'll talk about, this first step of tissue processing is extremely important to make sure that all of the DNA and the RNA and all of the cellular processes are arrested in the time and the way that you need them to, so that you can do testing later on. So heretofore, we really haven't changed too much of this step of tissue processing. And I know that a lot of things have gotten faster. This is not one of them, not in a way that we've been able to do that doesn't have consequences later on. And I know a lot of times when I say that I work in the laboratory, the first question is, what? And then the second question is, why do things take so long? And I'm really hoping to explain the multifactorial and multi-step processes that sort of hinge on each other, to explain why sometimes it feels like 24 hours, 48 hours. I know it feels like a lifetime. So once the blocks have come out of their chemical bath, we put them into something called paraffin. It's not as nice as the stuff you get at the spa for your hands and your feet, but it's similar. So we put them into a wax casting, basically, and this fixes them in place, so they're not flopping around when we're trying to cut sections through it. This is the hands of one of our histotechs who comes in early in the morning and unloads all of the blocks and then puts them into the paraffin like this. After that, we cut into glass slides like here. They're very thin, in general 4 microns, thin enough for light to pass through, and that's really how we are able to examine the tissue. But if you see, once we're cutting it 4 microns thin, everything is actually clear or a very, very pale yellow, and it's actually impossible to see detail. So instead what we do is we put them into a machine that stains everything. So it gives them a dye. We use 2 different dyes, and then depending on the amount of proteins that are in certain cells, they look more blue or more pink or red. And this is a picture of an example one. So you see some blue and some pink, and we'll get closer and we'll take a look at what they look like. This is also an automated machine, and it's continuous, which means that there's a basket that starts on one end and it goes through all these different dipping little dip containers, basically. And at one time, each basket can hold about 40, and so it's continuously processing. And at the other end of it is me. So this is not me on the upper left, but a representation of me. And I like these pictures in concert all together because I like to show that it's not just one person working by themselves, talking to themselves in their office. I do that a lot, but I also talk to my colleagues. And you see we have these very large conference rooms with multiple microscope heads, and we all sit around a room and we debate certain questions, or if there's an equivocal sort of judgment call, that's really helpful to work with your colleagues who also have expertise in this field. A lot of this is an art and interpretive and subjective. And I know that's really difficult because I wish I could tell you there was a black and white answer, but I think this group more than anybody understands that a lot of times it comes down to experience or interpretation or a whole picture with lots and lots of different pieces put together. And one of my many jobs is to pull together all these comprehensive pieces and try to give you the most cohesive report with an assessment and honestly sometimes an opinion or a commentary about what I think is happening. Now, this isn't all the time. Most of the time cases are fairly straightforward, but it's especially at City of Hope, especially with Dr. Lee's patients, I tend to get some conundrums that really make you take a walk, take a good think, and then consult your colleagues. So I'm very grateful that at City of Hope we have a number of colleagues in both pathology and in oncology and surgery and radiology that I can call upon. So the bottom photo is taken from Wikipedia Commons. I like it a lot because it shows that this is a pathologist who's looking at a microscope, and this is a double-headed microscope, and next to him or in front of him is a surgeon who's come downstairs from the operating room to come and look at the specimen together. And this might be one of my favorite things about working at a hospital is that surgeons and the radiologists and the oncologists all get together, and we have something called Tumor Board, and we have intraoperative consultations where we talk about your case in specific, and we talk about particular questions. And it's always helpful for me to understand context. If I am diagnosing an entity in a vacuum, that really doesn't serve anybody. And I'm also at risk for saying something that makes no sense and ends up, the onus of sort of resolving that conflict ends up on you. And so one of my big goals is to have the pathologists, the surgeons, the oncologists, and the radiologists talk together about what it is we're looking at and whether or not things make sense. That's not even the end of the story. So usually I am writing a report by that point, but there's a lot of other things that I can use. There's a lot of tools now. To be a pathologist means to understand a lot of these tools. So we have something called immunohistochemistry, which we'll talk about a little bit later. I'll show you slides of some common immunohistochemical antibodies that we use to diagnose neuroendocrine neoplasms. We also have something called molecular testing. A lot of these machines are now so small that they fit on a tabletop. They used to take up a whole room, but now they look like fancy microwave ovens or toaster ovens, to be honest. And we do a lot of molecular sequencing, and we do a lot of understanding the molecular drivers of tumors. And then something you may hear, not necessarily with neuroendocrine neoplasms, but with other solid tumors, is something called FISH, which is fluorescent in situ hybridization, which is another way to try to figure out what kind of mutations or chemical or DNA drivers are behind certain tumors. And all of this is to say that they take time. They take time to decide whether or not to use them. They take time to decide whether or not they would be useful in our clinical context. And once we start running the molecular testing in particular, it can take some time to have that data available and analyzed. The quoted time is about 2 weeks. So things can continue to keep going, but a lot of the testing takes more time than we're used to. And certainly looking at all of the picture together can take a little bit of extra time. Next, I wanted to go over the components of a pathology report. If we'd been able to have this in person, I actually had these nice handouts that were created, printed out. Lindsay was nice enough to do that for us, but you can actually find them yourself at this website down here. And it's a much larger version. It's a PDF that kind of helps you, it's an infographic that helps you go through what your pathology report looks like. If you have your pathology report in front of you, I welcome you to come and sort of pick out these parts that I'm about to go over with me at the same time. So the first thing you should do, the number one step, always, 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 is it your name? Is it your date of birth? Is this the surgery or biopsy that you had? That's the first thing, right? If it's not your report, then stop. Someone, we grab things out of the printer by accident. We open up someone else's, maybe your spouse or your child's pathology report came in and you grabbed it and thought it was yours. Always look first to make sure this is the correct person. Make sure that they have your date of birth correct, things like that. The next thing we might want to look at, certainly the most exciting portion, is called the final diagnosis. And then there are a few other places that might have nuggets of information that are interesting to you. The microscopic description, the gross description, and the synoptic report. I do want to say here that a pathology report has a lot of audiences. And what I mean by that is when I write it, I think about 3 distinct groups of people. The first person I think about is you, the patient or the caregiver. I think about what it is you want to know. I think about what it is, if it's important to call out, and giving a diagnosis as thoroughly and as accurately as possible, in as few words as possible, too. I'm not paid by the word, so I try to be brief and I try to make the points matter. The second audience that I think of are my colleagues, my clinical colleagues. So Dr. Lee, an oncologist who might be trying to decide between different therapies, Dr. Singh, a surgeon who went in and took out a portion of the liver, what is he interested in? The interventional radiologist who may have done an embolic procedure beforehand or has interest in knowing whether or not the pre-surgical interventions were of use, and possibly the future physicians who might be looking at this report years down the line trying to decide how to work with a recurrence or with ongoing care. The third audience that I think about is my fellow pathologists. I'll go into a little bit of detail later, but we very commonly, and as a routine actually at City of Hope, do an outside slide review of prior procedures. And by that I mean if you are a new patient coming to City of Hope, it's in your and my best interest to review the prior pathology reports and slides from your prior biopsies and your prior surgeries. And so when I'm writing it, I assume these slides will be going somewhere else at some interval of time. And I want to convey to other pathologists my work, right? I'm going to show my chicken scratch work. Here's how I came up with this. Here's how I came up with this. These are my thought processes, and this is why I ended up writing the way I did in the final diagnosis. So sometimes I think because there's so many audiences, it's difficult to know if I meant, I think people when they're reading it, they worry that they don't understand every word. And I want to tell you that if you don't understand every word, I think that's fine. And it's also because this is a really long and complicated report that is meant for different people at different times to be referring to. So the final diagnosis, the big ticket. In your final diagnosis, hopefully these are some of the components that are described. Where is it? What is it? Is it a neuroendocrine tumor? Is it a neuroendocrine carcinoma? In the lung, we frequently still call it a carcinoid or an atypical carcinoid. A large cell neuroendocrine carcinoma or a small cell neuroendocrine carcinoma, whether or not we say something like well differentiated or poorly differentiated, and then the WHO grade. So one of the things is that neuroendocrine neoplasms, with their categorization and the way that we call them certain things, have historically been under four different purviews. So the International Agency for Research on Cancer, which is an organization under the World Health Organization, publishes something called the Classification of Tumors, and we call them colloquially the WHO Blue Books because the books are blue, and there's new ones that come out maybe every 5 to 6 years. So these are pathology, generally experts who meet together and they decide how we classify certain things. Now, that makes a lot of sense if you are talking about a breast cancer or a breast neoplasm because it's one organ and they all get together and they talk about it, and that's the end of that. Or if you're talking about tumors of the kidney, primarily from the kidney, they get together, they talk about tumors of the kidney, and that's the end of that. Unfortunately, for neuroendocrine neoplasms, they tend to happen in a lot of different places, a lot of different organs. So you have the pancreas, you have the GI tract, and not just the GI tract, there's neuroendocrine neoplasms of the stomach, of the small intestine, of the appendix, of the colon, and of the rectum. And then you have neuroendocrine neoplasms in the lung, and rarely neuroendocrine neoplasms of the kidney, of the GYN tract, really anywhere. And that's partly because of the stem cell that neuroendocrine cells arise from. They really travel all over the body. It's not unlike melanoma in that it really can occur in a lot of different places. So unfortunately, because historically we are divided by organs, there's a lot of different ways that we have categorized them depending on where you are in the body. On microscopic examination, I might show you something like this. So this is, here at the bottom is the actual final diagnosis. So this is called a well-differentiated neuroendocrine tumor, NET. It's grade 1, and then it's in the pancreas. So over on the left, I wanted to show this is what normal pancreas looks like. So these are exocrine pancreas, which means that it helps you digest your food. And it's what we use, it's what secretes digestive enzymes, right? And this is on the right, a neuroendocrine tumor. And I like it because it looks kind of like a zebra stripe. But you see, this is a fairly well organized tumor. It comes out in long strands like this. They all sort of are lined up like us at the grocery store. They are not respecting 6 feet of space, that's for sure. But they are well lined up and they're fairly well, they look like one another, right? So this is a well differentiated tumor. I might also show a picture of a gastrointestinal one. So this is a small bowel, here, small intestine. This is normal small intestine. This is, these are the villi that we use, that our intestines use to absorb nutrients and to absorb water. And underneath it, you see these nice nests of tumor. So this is also well differentiated because they're fairly cohesive, they look like one another, and I can tell from looking at them over and over again that this is probably going to be a neuroendocrine cell just by the look of it. A lot of pathology is pattern recognition, and so I'm really good at picking out patterns. Here is a neuroendocrine tumor. This is also well differentiated, but it's grade 2. We'll get into why one is called grade 1 and the other is called grade 2. This is the tumor. It's a little more jumbled, I would say, right? They look a little less organized, a little more crowded and funny sized, funny shaped. Over here on the right is a very unhappy liver who has had to share space with this tumor. And so one of the things I do when I look at the neuroendocrine tumors that have been resected from the liver is I measure and see how wide they are. And then I also try to see if the ones in the liver have a higher proliferation rate than the ones in the primary small intestine or in the pancreas. And here is a picture of a poorly differentiated neuroendocrine carcinoma of the lung. This one is the small cell variant. It looks markedly different from the prior two in that the cells are very dark and they kind of smush all together. There's a lot of these little, we call them necrosis, so it's little crushed looking cells right here. And using the immunohistochemistry that we have, we can also show that it's got a high proliferation rate, and this is why it was called a small cell carcinoma as opposed to a neuroendocrine tumor. Another portion that you might see in a microscopic examination section is immunohistochemistry. So they're brown, they tend to be brown, sometimes they're red, stains that show antibodies to certain proteins that we have in our cells. So most famous, I think, in neuroendocrine cells, basically of all sorts, are synaptophysin and chromogranin. Those are our two standbys. You might have also heard about them because we tend to measure chromogranin, especially in the serum, in the blood. And so you might have seen that in both, and that those are markers for these particular kinds of cells. Some of the newer ones you may hear about, these are definitely our favorites and the most consistent ones that we've used. Some of the up and coming antibodies that you might hear about are called INSM1, islet1, things like that. And they all tend to be, some of them tend to be specific to an organ, a lot of them are not specific to an organ, and they all tend to be close to this neuroendocrine lineage from cells. I talked a little bit previously about the fact that the WHO helps us with a grading system. And here is one of the cons of having so many different organ systems to come up with your own grading system. Remarkably, they're fairly similar, they're fairly close, but there's a few portions of the grading system that matter in one and don't matter in the other organ system. So we're trying really hard to kind of corral everything together and make it like one overall framework. But so far, you definitely will hear about a mitotic count. We'll go over how to do a mitotic count. If anyone gets really good at it, I am very tired of them, so you can come and help me in my office. And we can wear face masks, don't worry. And then Ki-67 Proliferation Index is sometimes used in some of the organ systems, and then necrosis is used sometimes in other organ systems. In 2018, the WHO said, okay, guys, we're gonna bring it all under one umbrella and we're all gonna decide what's going on here. And they proposed this classification. It has not been widely adopted, because if you think it's tough corralling a bunch of toddlers when everyone's at stay at home, you should see pathologists in a group meeting. They're very opinionated, and they have a lot of ideas. So far, the proposed classification is still a proposed classification. A lot of people have adopted it, but it is not necessarily a rule across the land. So you may see some variations in your own reports. This is also fairly new. They came up with it in 2018. It was published in 2019, and I heard about it at some meetings in 2020. So it's going to slowly start percolating through the community of pathologists, I think. But I wouldn't worry too much. I don't want you to worry too much if you don't see exactly these terms that I'm talking about, because again, this is trying to undo decades to hundreds of years of people grading these systems depending on which organ it's in, as opposed to as an umbrella term. So the umbrella term that has been proposed is neuroendocrine neoplasm. So I don't know if LACNETS will turn into LANENS, I'm not sure, but this is what we have come up with. So and underneath neuroendocrine neoplasms, you have either neuroendocrine tumors or neuroendocrine carcinoma. So this is what we have been working with up until 2017. We talked a little bit about the fact that most of them are in the pancreas, the GI tract, or the lung. And you can see there's kind of a difference between them in terms of who goes where. So in 2017, I think most notably in the lung, necrosis is a criterion, but Ki-67 is not. Right? So I've had some people ask me, oh, about my carcinoid, how come there's no Ki-67 or it's not used? And that's because up until 2017, and even now, there really is no mandate to use it. It's helpful, but it's not necessary. And that's a little bit frustrating, I think, because it can feel like nobody's in charge, or we're all just using what we have, and that is true. But I think what you'll notice is that across the board, they typically look about very similar to one another, which is also lending credence to the idea that like there is a more cohesive way for us to describe them. So notably in the pancreas, what was proposed earlier than 2018 was that a well-differentiated NET and calling it a grade 3. This doesn't exist in the GI tract, or it didn't exist in the GI tract, and it didn't exist in the lung in the 2010 and 2015 versions of the WHO Blue Book. So the new classification proposal looks like this, and the tables I realize are this way or this way, so I apologize, but we'll go over it briefly. So here's the pancreas, and as I mentioned before, here is grade 3 NETs, and then you have small cell neuroendocrine carcinoma and large cell neuroendocrine carcinoma. So this is the newer category that came out in 2017 with regards to the pancreas. You'll see the lung has kept just grade 1 and grade 1 atypical, oh, sorry, this should say grade 2, atypical carcinoid, small cell and large cell carcinoma. But you'll see across the way that they tend to look very similar, and the larger division is between neuroendocrine tumor and neuroendocrine carcinoma. So here, I guess they're going to call them families. And then in the uterus and cervix, although uncommon in terms of numbers, it does happen. And so it's the same idea of calling them grade 1, 2, and 3 neuroendocrine tumors versus neuroendocrine carcinomas. So most of the organ systems, with the exception of lung, have long used the Ki-67 Proliferation Index as a criterion for grading tumors. And over here on the left is my handwriting, and this was me taking a picture and then tallying by hand how many stained brown cells there were. And the recommendation is to count at least 500 cells, is to look for what we call a hot spot, so an area that looks like it's more rapidly proliferating, count at least 500 cells in that area, up to 2,000 cells, and then giving that number. We run into trouble with this most frequently with needle core biopsies or small preoperative biopsies. It can be really difficult to know whether or not the place that you're counting is even the correct place. There is a lot of variability in these tumors. And so I always tell Dr. Lee, I tell Dr. Singh, a low number doesn't necessarily mean there's nothing else higher kind of around the corner that the needle just didn't get. We have come a ways, and now we have digital cameras and we have robots that will count it for us. If you look closely, the blue cells have these little green dots on them, and then the dark brown cells, that's the antibody label, is also counted separately, and then it can count. This one has counted almost 1,200 cells in, honestly, like a split second. So much faster than me, pretty accurate, and is also capable of really finding lots and lots of different places that might be of interest. And then it'll give you a % positivity here. These two, I think, are from different cases, so I wasn't too far off. Okay, another thing that we do, and this is across all of the organ systems, including the lung, is the mitotic count. So a real brief cell biology primer. Mitosis is the process of DNA replication during cell division. This is a cartoon over on the top right showing you what it looks like. For our purposes, it's a quick way to describe how often the tumor is dividing, right? So if you are replicating during cell division, the assumption is that you're going to go from 1 cell to 2. This is what it looks like under the microscope. They look like, to me, they look like little fuzzy caterpillars. And I end up counting at least 50 high-powered fields, and then it's reported as mitoses per 10 high-powered fields. So I'll count 50 and then divide and report it out as a ratio. So we've talked a little bit about what it looks like to read a pathology report. Let's go through an example. So this is from a real case from a few years ago, and it looks like a lot of words, but if you want to pick out what's most important, where is it? It's the pancreas, right? What is it? This is a neuroendocrine tumor. What is the differentiation? It's well differentiated. And what is the grade? It's grade 2. And underneath it, I didn't highlight it, but you can see the reason that I called it a grade 2 is that the mitoses average 1 out of 10 high-powered fields. Here, I'll tell you, I counted 100 high-powered fields. It's a real overachiever that day. And then my Ki-67 proliferative index in hotspots was up to 4.5%. And for this reason, actually, the 4.5%, this is how I ended up at a grade 2. If the mitotic count and the Ki-67, we're in a pancreas, so I use both. If one is higher than the other, I use the one that's higher. So now we go down to the microscopic description, and you'll see I wrote this whole paragraph, and this paragraph, to be honest with you, is for the other pathologists, right? So if a pathologist is going to be seeing this 2 or 3 years down the line, I'd like them to know what I was thinking that day and what I was doing. And of your interest, this is the Ki-67, and I reported here. Here I gave a range, and I gave you the total number of cells counted. So here I'm showing my work, right? Here's I'm doing the arithmetic, and I'm showing what's going on. Okay, so it might seem like, oh, I'm done and I've signed out a report, and my name comes down on a little stamp with a little timestamp. It's very cute, and that's the end of that. But absolutely not. What ends up happening is that these glass slides at City of Hope are retained. Our policy is forever. For most states, it's 10 years. Certainly now that we're moving everything towards digital, I never thought I would be talking to everyone over the internet while everyone was sheltering at home. So a lot of stuff has changed. Pathology is now getting digitized at a much faster rate than we ever imagined. And a lot of slides are being archived digitally as opposed to manually. Although right now we've got both going on here. So what ends up happening is that slides, digital or glass, can be re-reviewed at a multidisciplinary tumor board. At City of Hope, we meet every 2 weeks on a Wednesday, and we talk about patients who are coming in, their follow-up or their new patients, and we talk about what it looked like and if anything's changed. So if anything's changed or there's anything new going on, I tend to review back all the old material that we have just to see if there was something that I might have missed, or to really show side by side if something has progressed or stayed exactly the same. Sometimes I'll pick out a biopsy or a resection from 5 years ago and I put it right next to the new biopsy, and they look either remarkably similar or very different. And I like to show the difference between the two. The other thing is that slides or blocks. So this material is retained by the hospital and can be sent anywhere you would like for a second opinion. Certainly, if you're going to go to a different hospital, or if you've moved from New York to here to Texas, and you are setting up your new care, I highly encourage you to make sure your material is sent to your pathologist at your new hospital or healthcare system, so that they have an understanding of what it is you've been through. And the other thing is that some people have asked me, like, oh, do you take offense if people ask for a second opinion? No, never. It's really important that you feel comfortable with the kind of care that you're getting, and that you get an understanding that people are all on board with the same idea. And so whether it's at Tumor Board or if it's a second opinion, I highly recommend people make sure that they are comfortable that pathology is part of it. You're going to go see a surgeon, you're going to see a second surgeon to get a second opinion. It's really the same thing for a pathologist. You just don't necessarily get to pick me from a directory, and I don't have fancy pictures the way Dr. Lee does. And I just wanted to show you one last picture, series of pictures, and these are our lab staff, a number of our lab staff here. It's not even all of them, there's so many of us. And I wanted to say that even though you don't see us necessarily, we think about you all the time, and we're working so hard, and I'm so proud of our staff. They think about how to do the best thing for our patients every day. And I get to stand up here and talk about it, but they're really doing so much of the work. So I'm very, very proud of them. And here we go is from an epilogue, the little picture of the tissue from the beginning, and here is the neuroendocrine tumor. So that is the end of my talk, and I guess we'll have time for questions.
Thank you, Dr. Chang, for a really excellent presentation. This really was very interesting and entertaining too, and you made a topic that's often very confusing to many of us much clearer. So we really thank you for that. It's amazing to me how even the report is a lot more complex than we think. I mean, we think the language is complex, but even the way you think about it. And it was interesting to me to hear that you're saying patients look at it, colleagues are looking at it, pathologists, and that's something that I had never really thought about. So I really want to thank you for that. So we have several questions that came in. One is just to clarify again about, well, while we might not be changing our name to LACNETS to go with the new WHO.
I didn't want to stress anyone out, but like maybe just like get that URL now.
That's funny. What's the difference or distinction between neuroendocrine tumor and neuroendocrine carcinoma? If you can just kind of clarify that a little bit more.
Sure. I will go back a little bit to the chart.
Thank you.
And I would like Dr. Lee actually to weigh in if he could. His computer has decided to take a nap. Okay. Here we go. So for me, it's twofold, and unfortunately, you got me all ramped up. I'm going to start talking, kind of really get in the weeds. We think that it's to do with what the tumor drivers are inside the cells themselves. And the way that we end up categorizing them is often based on the synaptophysin or chromogranin that they're expressing in the cell itself, and how high the nuclear division rate is. So they tend to go hand in hand. They tend to be, and not always, and when they don't, they somehow end up on my desk, and they somehow end up as Dr. Lee's patients, magically. But they tend to go hand in hand, and they tend to be the ones that express a lot of the neuroendocrine proteins that we would expect, tend to have a lower proliferation index, and they look, on my inspection, they look like neuroendocrine tumors. And I think maybe, Dan, you can talk a little bit about prognostically, you seem to see a certain pattern. With the neuroendocrine carcinomas, they tend to have really high proliferation rates. They tend to divide, and they're more aggressive. And they tend to have lower expression of the proteins that you would expect for an anatomic neuroendocrine cell.
And Dan, if you can weigh in on that too. And I don't know if this is something you can comment a little bit more about too. Is there like a good or bad Ki-67, especially in specifics, like if you're starting to look at the different sites like lung, pancreas?
No, I mean, they're a marker, right? They're just a marker for, I guess, like different baskets that we put things in. So it's not binary, right? It's not yes or no, high or low. It's a tool in an armamentarium where, I mean, I end up having to integrate it all in my head. So, and there's sometimes when I am convinced that something is going to be higher grade, and I count and I count and I count, and I can't get the number to be high enough to be in the basket that I think it should be. And that's usually when I pick up the phone and I call Dan and I tell him, like, look, I know the number looks low, but I think that's falsely low. So a number is really just a number.
Yeah, so I think I can build on top of that with what Dr. Chang said. I think first of all, in terms of kind of the general difference between neuroendocrine tumor versus a neuroendocrine carcinoma per se, from a clinical standpoint, is as she mentioned, neuroendocrine carcinomas tend to be fairly aggressive. I would say neuroendocrine carcinomas traditionally underneath the microscope appear to be fairly irregular appearing, meaning poorly differentiated. And then oftentimes they divide very quickly. So these are the neuroendocrine cancers that are usually having Ki-67 proliferation indexes of greater than 55%, and usually are going to be up in the range of 70%, 80% or higher. So these are very aggressive malignancies, and as a result of that, traditionally we've been able to treat them with chemotherapy as frontline treatment. Whereas neuroendocrine tumors in general tend to be a little bit more indolent. Underneath the microscope, they might be more well-appearing across the board. And then you have somewhat of a large kind of gradient in that sense. Traditionally, they tend to divide a little bit more slower. Usually the Ki-67 proliferation index on average will be less than 20%. But now we are seeing more of kind of these rare entities where you have these well-differentiated neuroendocrine tumors, but they are dividing a little bit faster than what we traditionally see. So they can be, Ki-67 proliferation index of 30%, 40%, or even 50%. And I would say that really builds on kind of the second question that you asked, Lisa, in terms of what is a good or bad Ki-67. And I think you have to take this somewhat a step further. So traditionally, while we have thought that really high Ki-67 proliferation index is really bad in terms of aggressive nature of the disease, I will comment in the sense that at the same time, those types of tumors tend to respond to the chemotherapies that we have. Whereas these entities that are well-differentiated, grade 3, if their Ki-67 proliferation index are, let's say, around 45% or 50% or even 40%, those are really tumors that are very hard for us to treat sometimes because they don't respond as well to the traditional treatments that we would give for a well-differentiated neuroendocrine tumor that it has a Ki-67 that's less than 20%, but then they don't at the same time respond as well to the ones that are poorly differentiated neuroendocrine carcinomas where the Ki-67 proliferation index is closer to 70% or above 70%. So I would say, that's an area that's really an unmet need in terms of how do we really best treat these patients, and really trying to find additional resources so that we can really optimize and individualize treatment for those patients moving forward.
I like how you said, Dr. Chang, that well-differentiated line up properly. While they might not be social distancing, we see them lining up. So
yes,
that's kind of
like
what
little nests, little cute nests.
Okay. Whereas the poorly differentiated it wouldn't be lining up. They're not social distancing at all.
Oh,
clumping.
they're very nosy and they're all in each other's business.
Gotcha. So we'd rather not have that, is what you're saying, Dr. Lee. Thank you. And there's several questions that come up in the realm of metastases. So people are wondering really if there's different Ki-67 or pathologies for the metastases, and also when there's a surgery or when there's a metastases and say that that's removed, do you also look at the pathology for that along with the primary?
So we look at everything that comes out of the operating room under a microscope. And I would say that I tend to look pretty hard at both areas. And I tend to actually to try to find the one that's higher and run the Ki-67 on that and do the formal mitotic count on that one. So there's a difference between a formal mitotic count where I have to get really calm and I have to keep track of the number. If someone comes barges in my office, I lose all the track of the numbers and it's a mess. And looking with your eyes to sort of note to see where things look a little bit busier, right? So we look at everything, absolutely. Occasionally I'll run it on both just to sort of see the difference. In my experience, they tend to be pretty similar. They tend to have areas, both, say, for example, you have a pancreas primary and then with liver metastases that have come out at the same time, or a small bowel one with liver metastases. They tend to look similar. The apple doesn't fall far from the tree, I think is what I'm trying to say. Occasionally I'll get one where oh, it's surprisingly higher in this particular one. But for the most part, they tend to look like each other.
That's helpful. And along those lines, if you have metastases in different parts of the liver per se, and there's slices, say right side, left side, can the metastases vary as well?
They can. To me, they all, I think if Dr. Singh were here, what I've understood from sitting in Tumor Board quite a bit and hearing a lot of his talks is that a lot of times it's not what I've got under the microscope. That part is actually pretty unexciting. It's unsurprising. It's location, to be honest. And so there's nothing I can see under the microscope that looks particularly different from one another. And they tend to be, when he starts talking about it, it tends to be about the location more so than the mitotic count.
Gotcha. Okay, so Dr. Lee, I was wondering if you could comment on that, if nets are homogeneous or not.
I think for a lot of us, in terms of what we see, is that it is a heterogeneous disease in terms of heterogeneity from one patient to another, but also with the tumors themselves within one individual. So oftentimes, if you look at sometimes what you'll see is that the primary might actually have a slightly lower Ki-67 proliferation index compared to a liver metastasis or a distant site and everything. So that really tells you that in order to a lot of times try to optimize management in patients, you really have to make sure that you do your due diligence and address this heterogeneity. What do I mean by that? I think you're going to have a call next month about PRRT. But what do you do in a patient that you undergo a gallium scan and clearly you see that some of the lesions are gallium avid, but other lesions are not, saying that they are not necessarily somatostatin receptor active. So are you gonna really treat that patient with PRRT, or is it better to cover with a treatment that might encompass all of the disease? So that just really shows you and potentially demonstrate to you the heterogeneity within the tumor.
Okay. Dr. Lee brought up something that I wish I had said earlier. He's absolutely correct. And part of it is that the Ki-67 and the mitotic count that I see are only small components of really what's going on, right? Like it's like looking at a giant house through a tiny peephole. You can't see as much as you would want to see. And so a lot of times I'm actually surprised, because to me, I do a KI, I do a formal mitotic count, and it looks exactly the same to my eye. But then they'll show me, Dr. Lee will show the gallium scan, or they'll talk about uptake, and it'll look so different. And so I think a lot of times, because the Ki-67, the mitotic count, are in every report, we kind of we can hang our hat on that one. And I wanted to point out, and I think he illustrated it perfectly, that's not just because it looks the same doesn't mean it's the same thing happening in there.
Mm. So and thank you both for those, for clarifying. So if the tumors are heterogeneous, how do you decide? So say there's a range, right? 3% here and higher in a different place. How do you decide about treatment?
Yeah, so that's a very good question, and I think it really takes somewhat of an individualized approach. It depends on kind of the degree of heterogeneity that is ultimately involved. So if it is a scenario where, let's say, the primary lesion is a low-grade or G1 tumor, and the liver metastasis is a intermediate grade or G2 tumor, I mean, your management would be still geared towards the same thing, in the sense that we would traditionally treat G1s and G2 tumors very similarly. So that's an easy scenario to do. It's much more complicated if you have, let's say, some of the lesions, like I mentioned, are really behaving as lower grade tumors or intermediate grade tumors, and they have some SN receptor activity. But then you also have some of the lesions that don't, and they are maybe behaving a little bit more aggressively. In those scenarios, then I think you really have to give treatments that would either cover both, whether it's to go after the higher grade tumor, let's say if it's a pancreas neuroendocrine tumor with oral chemotherapy like CAPE-TEM, that will have activity for the slightly higher grade tumor, but then also have activity for the lower grade tumors. Or in other diseases, you might have to potentially combine your treatments somewhat, in the sense that you would give a treatment modality that will cover the slightly higher grade tumors, but then at the same time, maybe also use somatostatin analogs concurrently with that treatment to cover the lower grade tumors. So it really depends, and it's very somewhat individualized in terms of what you're seeing clinically for the patient.
Okay, so it's just one peephole, like you said. So that's one piece of the pie, and we have to look at the whole picture. So I guess as a patient, we don't really know what's going on, right, under the microscope and behind closed doors. So how do we know, how can we have confidence that the specimen was a good one? And when, if ever, would you biopsy again?
So glad there's no radiologists in the room who throw something at me, because I usually say rebiopsy is recommended. I think that is something that the doctor you have who had ordered the biopsy, who had requested the biopsy, right, your oncologist or your surgeon generally, would have this discussion with you. And frankly, sometimes I just pick up the phone and I say, you got to get another one. I can't tell. And a lot of times it says something like to that effect. And if there is a question, I think your oncologist will have a conversation. Again, this is why I really love Tumor Board, because it's a time where we can have some straight talk about what's the sequence of events.
Dr. Lee, do you have anything to add to that?
No, I agree. I think it's really, kind of in that Tumor Board multidisciplinary team kind of setting where you're able to have these discussions, very openly. And if something doesn't make sense in terms of what you're seeing at one versus, what might be is being seen like overall clinically, then that's a discussion of whether or not additional tissue might be needed.
Okay, yeah, so getting everyone in the room and having those conversations. And Dr. Chang, we really appreciate you saying that it's okay to get a second opinion. And that's really helpful because sometimes we as patients worry about offending our doctors or our team, who we know are working really hard for us, especially during these times. And so when you mentioned that the slides or blocks can be sent to for a second opinion, how is that done? And is there a cost to it? Is it easy to do? How do we as patients go about doing that?
Trying to be careful about how I say stuff. So in general, I actually would, the vast majority of time when I see slides that have been prepared at an outside hospital, it's because they've come to see Dr. Lee, Dr. Singh, Dr. Kessler, as a second opinion patient that way. And then it's just one follows the other, right? I'm like a pesky little sister who follows them constantly. Like, if you're gonna see him, I gotta see their stuff too. So I would actually say they tend to follow one right after the other. And then there are, if your oncologist is your surgeon is your primary key, I would say. If Dr. Lee wants to jump in, I actually don't solicit outside consultation reports, so I don't actually know how they just show up on my desk. But it usually is the treating clinician requesting a second pathologist.
Yeah, I mean, I think in general, we always like to, have confirmation just to make sure that there's congruence, and if there is not a congruence, then that might lead to additional thoughts in terms of whether or not we need to get additional samples or not.
That's helpful. And what if we're transferring care to another facility? Do we as the patient initiate that, or is that also the new clinician?
So I think, depending on where you go, most facilities will offer automatically for new patients that are coming into them to initiate a pathology review. So it also depends on, are you coming specifically for a second opinion consultation, or are you really transferring care? So if you're transferring care automatically, I would say most institutions, it will be pretty much reflex to say that they want to have the pathology reviewed at their institution to, again, confirm congruence with the results that have been reported. Sometimes for second opinion consultations, because it's a charge, and for some patients it's a self-pay second opinion consultation, the patient is given the option whether or not they want their pathology reviewed as well as part of the second opinion consultation, but usually that will carry a potential charge with it. So, I think it's really individualized and up to the patient if they would want that.
Okay, and in regard to the actual report, if we notice, or if it's shared with us, that there's an incorrect terminology used on the pathology report, carcinoma rather than carcinoid tumor or something like that, should we as patients be concerned about the wording?
So the first thing I want to say is this is an exciting, I know we're tired of being excited. It's an exciting time because this is the first time really there has been a global proposed universal classification. So I don't actually think it's wrong. You'll notice that there's a lot of slightly different ways of saying basically the same thing. And as long as your treatment team understands which general basket we're talking about, I don't think there's a wrong or a right word. So I really want to get away from that. There's a proposed guideline, and I like it myself, so I'm going to use it. But this isn't wrong or right in terms of the words that they use. So I think more important than that is that your pathologist and your oncologist or surgeon are on the same page about what this means, right? Otherwise, it's just semantics, honestly. And I want to also say that here at City of Hope, I see so many outside slides, so many outside reports, because we're a referral center, really. And I've been really impressed with the community practice pathologists and other academic institutions all over the country in terms of like, pathologists are real big on getting it right. So pathologists as a general rule, like really like to learn, like make sure they're really diligent. So I kind of want to make sure I'm not saying that one's right or wrong. I definitely am not saying that. What is the most important is that your team is on board with the general category or basket for moving forward.
Thanks for that clarification. And along the lines of, sending our specimens to other places, there's someone who's wondering how hard, or again, if there's a financial cost to sending maybe slices of our tumors to other tumor banks to help in their research.
That is something that unfortunately there's no general repository, or how do I say this, like clearinghouse, right? So we get some requests sometimes for smaller research firms or private biotech companies, and that really is unfortunately something that the individual has to sort of do due diligence over. Certainly the research that we do at City of Hope is separate from the clinical care that we provide.
Okay, so it really depends.
Yeah.
And there's several questions for Dr. Lee on the medical side. Definitely in these the unprecedented times with the coronavirus, there's concerns about people who have had their spleens removed for NET, and although given vaccines for various preventative reasons, how does living without the spleen affect one's immune system?
So I think that's a very good question in terms of the spleen. The spleen is a organ that's involved in terms of kind of where it's a reservoir where you have certain types of immune cells that allows you to fight certain types of bacteria, organisms. I think it's usually been more for bacterial organisms rather than viruses. So if we're specifically talking more about COVID-19, I think that's something that we have to kind of be cautious about and everything. But I think at the end of the day, we don't have really kind of consensus guidelines in terms of what to do around these times. I would say the most important thing to do is that just like any other treatment that you're going to get during your neuroendocrine tumor journey, everything is about kind of risks and benefits. And I would say that, as you're going through treatment during this unparalleled time, to have a discussion with your provider to discuss, what are the risks and benefits of treatment and everything for your individualized case, and make the decision based off of that.
Okay, so and of course this is a very challenging time, so this is a good opportunity to talk to your provider about what to do for our specific situation. There's a couple more pathology questions. One is, how common is mixed cell neuroendocrine carcinoma? So having adenocarcinoma and also neuroendocrine.
Neuroendocrine carcinoma.
Yes.
It's not uncommon, which is, I used to hate that phrase when I was in training, and now I use it not uncommonly. You're talking about a zebra within a zebra. I know the LACNETS or the NETS community uses the zebra iconography, and so common enough that it's in this classification system. We learn about it. So I don't actually know the numbers. I couldn't tell you, but they're all we're talking about esoterica, uncommon and uncommon things together.
The rare of the rares. Okay.
They're pretty rare.
And is there a way to differentiate pathology nets from mast cell disease?
There's also, I think there is, especially and particularly, and it should be with a larger testing and clinical context. So it's not just the biopsy, it would be some laboratory testing, some blood testing, imaging, and then a good correlation with the history of the illness itself. So yes, but never in a vacuum.
Dr. Lee, do you have anything else to add to those questions?
I don't think so.
Okay. And I think one last question. Thank you for taking all these questions. And Dr. Lee, since we know at City of Hope, you're the gatekeeper for PRRT and kind of coordinating that, which is different from other institutions. If you were doing PRRT, what kind of Ki-67 would you want the primary tumor to have, if that even matters?
Yeah, I mean, I ideally, I don't think it's necessarily just about the Ki-67. What's important is you have to make sure that your disease and your tumor really expresses somatostatin receptors, because if it does not, then the treatment that is specifically targeting somatostatin will not work. So I think that's much more important, whether or not it expresses somatostatin receptors throughout the various tumors that's out there, rather than a true cutoff point for the Ki-67.
Okay, so in that instance, the Ki-67 matters less than perhaps some of the other the other treatments. And one last question for you, Dr. Chang. What are pathologists looking for when they're doing stains for prolactin, ACTH, alpha subunit, and GH?
We're looking at what is the cell doing, in short, what's going on inside the cell. So those are all proteins that are expressed or not expressed, and very similar but not the same as synaptophytes and chromogranin. I just want to know what's going on inside there. And it's an attempt to classify certain tumors. So not all tumors need it, but if it's being done, it's an attempt to put it in a basket of a sort.
And is that something routinely done with NET?
Some NETs, not all.
Okay. And what kind of NETs would that be?
So it also depends on where you practice. And so on your pituitary, sorry, did you say prolactin and?
Yep. ACTH.
ACTH. So it tends to be things in the pituitary axis that we might have interest in doing that. Certainly we might do it if there's different questions. So again, the stains are to answer certain questions, and the questions might change. Historically, they're for pituitary adenomas.
Gotcha. Okay. And then would it be possible to have both pituitary adenoma and NET?
Yes. Yes.
Okay. Okay. Well, thank you both for this really thorough question and answer time. Our audience has been very appreciative. And just a reminder to everyone that the videos will be live on our YouTube page in less than 2 weeks, which is YouTube.com/LACNETS, LACNETS, and the letter C. So YouTube.com/LACNETS and the letter C. And as Lindsay said in the beginning, join us for our upcoming webinars. We have one in April on PRRT, one in May on what matters most, meaningful advanced care planning as a gift to your loved ones by Red Wing Kaiser. That'll be May 6th. And the April 14th one, which is in just a few weeks, will be on PRRT with Dr. Thomas Hope and the NorCal Carcinet President and Patient Advocate Extraordinaire, Josh Mailman, and Linda Gardner, who's the UCLA nurse who runs the PRT there. You can go to our website, the RSVP at lacnets.org/upcoming-meetings. That's lacnets.org/upcoming-meetings. And if you're not able to watch the entire webinar, or if you think others might benefit from this, you can always go back to our Facebook page and watch it again from the beginning. And again, it'll be up on our YouTube page in less than 2 weeks. We want to thank again our hosting institution, City of Hope, Dr. Dan Lee, the co-director of the NET program there, Dr. Sue Chang, the City of Hope AV team, especially Antonio, and to the whole NET team. Thank you for all of your support, all you do on behalf of the NET patients and community. We really appreciate you very much. And together, we will keep dreaming big and reaching for the stars. Thank you.